My name is Dr. Oscar Ramirez, plastic surgeon in Ventura, Florida. Back in the 90s, at the beginning of the 90s, I designed a series of instruments for Snowden Pencer that was used for endoscopic forehead, midface, and endoscopic cervicoplasty. Now with Marina Medical, we have redesigned those instruments, and we have made a set which has a lot of improvements compared with the old ones. So if you see this set, this is a little more lighter set with less instrumentation and has other important features. Some of the instruments has a much sharper edges, which allows quicker dissection, and some of them has a attachment of a suction device, so at the same time that you are dissecting, you can aspirate the fluids and some of the blood that you see in your optical field. So let's start now with the endoforehead to see how these instruments are used. The endoscopic forehead lift, I do it with 4 incisions, 2 paramedian incisions, and 1 in the temporal area. I won't go into the details of this because it's a topic for another lecture. So after I make my incision in the temporal area and I identify the temporal fascia proper, which is the white glistening structure in the temporal area, then I use the elevator number 4 to dissect on top of the temporal fascia proper and underneath the temporal parietalis fascia. So this is a very easy plane to dissect inferiorly, medially, and posteriorly. So when I reach the area where the sentinel vein is located, and also to preserve the temporal the zygomatic temporal nerves, I use this elevator number 0, and I dissect in between those structures until I reach the bony border of the lateral orbital rim and the superior border of the zygomatic arch. Then when I completed this, I come to the area of the temporal crest, the temporal line of fusion, and I'm using the elevator number 8, which was the original number 8. I dissect and elevate the periosteum. In that way, the connection between the plane of the temporal fascia proper and the bone are made much easier than if you come from the medial approach and you come subperiosteally and tend to go into the temporal area. You're going to tend to elevate the temporal fascia proper attachment into the temporal crest, and you're going to end up in the plane where the muscle is located. So it's safer to come for that from lateral to medial. So when you have done the dissection of the subperiosteal plane here, and having done this on the contralateral side, I come from the frontal approach, and using these 2 paramedian incisions, I go subperiosteally, and as I go more inferiorly, I use this little more curved elevator. So medially, there's no problem to go subperiosteally until the lower boundaries of the glabella. Whenever you are close to where the supraorbital and supratrochlear nerves exit, you have to be a little more careful. So I use a different instrumentation, and I come from the lateral approach. Initially, I can even use the 0 elevator, or I use this a little more gentle elevator, the number -2 elevator from the original series, and then I stop at this point. In the past, I used to go all the way to the arcus marginalis, and that created a potential problem of traction in these nerves, particularly the supraorbital nerve, and producing traction neuropathy. So if you leave the periosteum temporarily, then you're gonna prevent the traction on those nerves. So when I come here, then I identify the supratrochlear and supraorbital nerve before I do the resection of the corrugator muscle. So using also another set that we have, which is the manipulators. So we have a curved down, double curved down scissors. Then I spread it around the supraorbital and supratrochlear nerves, and then I resect the corrugator muscle using the specific punch. So only after that, then I do the release of the periosteum close to the arcus marginalis. So in that way, the nerves are not under undue traction while you are doing your dissection. And then using the same approach, putting your endoscope here and then your manipulators here, I do transection of the procedures in the lower boundaries of the glabella. I don't resect the procedures in the majority of the cases, I only divide it. So now you have the division of the procedures that have been dissected around the supraorbital and supratrochlear nerves. The corrugator has been resected. And then the last step is to release the periosteum. So the periosteum is released about 3 to 5 millimeters above the arcus marginalis. In that way, you don't skeletonize too much here. And really, you don't need it because the brow tissue actually is above this point. It's just overhanging. So whenever you release that, the brow is going to be elevated. So I come also from the temporal approach, and I transect the periosteum. So in that way, everything is ready. You elevate your forehead, you do your fixation, and again, this is the details of those are for another lecture. So now, what happens when I come to the when I want to go to the midface? So once completed the dissection before the fixation of the forehead, I come to the superior border of the zygomatic arch. As I mentioned, I use this zero elevator until I reach the superior border. When I identify the superior border, then I use the elevator number 9 and elevate the periosteum of the zygomatic arch. And as you see here, this is the trajectory of the frontal nerve. So the frontal nerve crosses the zygomatic arch in the middle third. So that's where it's going to be the danger of injuring this nerve. So if you elevate the periosteum, you're going to be safe because the nerve is going to be in your elevated flap. So when you continue the dissection, then you're going to find the attachment of the masseter to the inferior border of the zygomatic arch. So the fascia that covers the tendon of the masseter is elevated with this elevator. So in that way, you are almost in the premasseteric space where it's going to allow to have greater mobility of the midface for the vertical elevation. So when you have done this dissection in here, including the lateral border of the orbital rim up to the level of the tendon, of the canthal tendon. So you stop here and come from the intraoral approach. So you make your incision on the gingival-buccal sulcus, and using the elevator number, again the elevator number 9, you dissect the periosteum, being sure that you are not injuring the infraorbital nerve, and then going around that, you come and connect with the dissection done from the superior approach on the malar bone. So now you have dissected the maxilla, the malar bone, the zygomatic arch, the lateral orbital rim, and then you still leave the periosteum attachment medial to the infraorbital nerve, again to preserve this nerve and avoid traction neuropathy. So a lot of the neuropathy is related to the traction. So the midface is approached through the intraoral incision. You make about a 1.5 centimeter incision of the gingival-buccal sulcus, and then you go immediately subperiosteally with the elevator number 9, and you dissect the maxilla, leaving still attached the periosteum around the infraorbital nerve. Then whenever you come laterally, you go to the malar bone and connect the dissection that you have started from the temporal approach with the midface. Now the maxilla, the malar bone, the lateral orbital rim, and the zygomatic arch are dissected. And then you apply your suture suspension on the midface, and after you have done that, before you do the fixation, you dissect medially around the infraorbital nerve and along the inferior orbital rim. In that way, all the previous manipulation won't create a lot of traction on the nerve. The key is trying to preserve the nerve and avoid traction neuropathy. So after the sutures for the fixation has been placed, then you come medially and dissect the medial portion of the periosteum medial to the infraorbital nerve. Now, as you see in here, the infraorbital nerve is in here. I'm putting my mark. So now, coming with the elevator -4, you come to elevate the inferior border of the orbital rim. So that way the periosteum is released, and then whenever you're gonna do your lifting and superior suspension, the orbicularis oculi muscle also is gonna be under tension, and it's gonna allow you improvement of the tia trough and the laxity of the lower orbicularis. So this is a very useful instrument. This is the -4 instrument. Now, there are other instruments that help you to do some additional maneuvers that you want to do. And this is the elevator that has curved down, double curved down, that if you want to dissect more in some heavy brows along the arcus marginalis and go in the border itself, this allows you this dissection. So that kind of breaks the arcus marginalis at the orbit itself. The other instrument is this other that has one curve in this direction and the curve in the opposite direction. This is the instrument I use whenever I want to stretch the fascia and the periosteum and the fascia deep to the orbicularis oculi muscle. In that way, this this muscle is going to be splayed out, and for those that have a lot of CrossFit, this maneuver is going to help to redrape better the lateral portion of the orbicularis oculi muscle. Also, this instrument helps you to separate more, because after you have made the periosteal release, you need to separate it if you want to elevate more, especially the lateral border, the lateral portion of the brow. So this is going to be separating the periosteum, and I call it periosteal spreader for that reason. So these are basically the maneuvers that I use for my endoforehead and endo-midface, and the instruments that are used for each one of the areas. Obviously, you can do with the lesser instrumentation, but I compare this type of surgery with golf. When you play golf, you have a different type of shapes of clubs, and that to do the different maneuvers. So your handicap is going to improve if you use properly each one of those clubs. So the same way with the endoscopic forehead and mid-face lift, your results are going to be better if you do the dissection properly, because a lot of problems that have been mentioned about the relapse of the endoforehead was probably due to insufficient release of the structures and insufficient removal of the corrugator muscle and lack of release of the process. When you do all this release and release the periosteum of the superior orbital rim, all this compound flap is going to come and is going to be move upward very easily. Now, when you want to improve even more the lifting of the midface, you can come from the intraoral approach and connect and dissect more in front of the tendon of the masseter muscle. Remember, part of the dissection was done from the temporal approach. Now you can connect it and go a little bit more laterally toward the pre-masseteric space. In that way, whenever you do your lifting, this is gonna be elevated without any restriction, and then it's gonna be very easily to transmit that lifting to the lower cheek jowl area. Now, whenever you want to do a standard open cervical facial lift, I use this elevator, the number 4 elevator, to do a soft tissue elevation dissection at the plane between the SMAS and the subcutaneous fat, and it's very easy. And then you can see any vessel that there you can coagulate it. I don't use the scissors. I use the scissors at the beginning, and then I introduce this instrument and I dissect it in a very anatomical plane. That is probably very similar to the Viterbo and Trepsat instrument that has double blades and use like scissors without cutting. So this is I elevate my flap and I keep dissecting. Particularly for the cervical facial, for the cervical component of the cervical facial, I use this to separate on top of the platysma. So you identify the platysma and just keep dissecting on top of the platysma. And as I mentioned, I don't use much of the scissors. And with this instrument, the dissection is much clearer and more anatomical. Obviously, whenever you want to do the dissection in the midline, from the lateral approach, this becomes a little bit too rigid, too straight. So I use an instrument that is the same blade, number 4 blade, but is a curve, so you can come all the way through the midline and beyond to do the dissection from the lateral approach. The same way when if you want to complement that through the submental approach, then the curvature allows to lift the flap and you can see better, as opposed to the straight instrument that is in your way. So the curved instrumentation helps for the neck, and the flat number 4 helps for the cervical fascia. So this, I call it the universal dissector. Helps to do a lot of soft tissue dissection on different parts of the body, particularly in the face. So that's the brief explanation of the use of the instrumentation for endoscopic forehead lift, endo-midface and endo-midface or open cervicofacial lift. Thank you very much. So as a final comments, I would like to invite you to visit me to see these operations. And if you want a more hands-on type of training, Marina Medical is now offering hands-on training for surgeons who wants to learn different procedures, and among them are the endoscopic operations. Thank you very much.